Great. We're here at COPHy with Dr. Kitchens from the Retina Associates of Kentucky. Thank you so much, Dr. Kitchens, for joining us.
Thanks, Simran.
How are you liking Athens and COPHy so far?
First time here.
Nice.
Not my first time at COPHy. COPHy's a great conference.
Yeah.
It's actually one of the first international conferences I ever went to. 10 years ago, plus or minus, it was in Sorrento. And it was so amazing to have a conference that's focused around debates.
Yeah.
That's the fun part.
Yeah.
What we do is that you get to debate a lot of things. There's so many interesting things and so many controversial things that it's just a joy. In Greece, the weather's great.
You can't ask for anything better. Right? Yeah. So let's go down to, I guess, more the discussion and the debate topic, because I think that really is a favorite of what COPHy really is all about. And so with this, is there certain controversies or discussions that have happened that you're like, oh, wow, that's actually pretty cool, and I never thought about it that way?
Yeah, so I'll tell you, really what we're thinking about now is the newer generation of anti-VEGF medicines, including faricimab and 8 milligrams of aflibercept, compared to our older medicines. Yeah. And what are some of the benefits of each? And I think all the medicines still have a role and a place in our society. But what are those advantages, and how can we take advantage of those to the betterment of our patients? And what I love about the 8 milligrams of aflibercept is it's really kind of like Eylea Extreme. Yeah. And one name in the U.S. it's called Eylea HD, but it allows us to do some extreme things that we just didn't do before. Yeah. We're able to treat and extend patients out more aggressively. We're taking patients that are stable at 8 to 10 weeks and be able to get them out with the third fewer injections over the year. And so it's really been a game changer for us.
Yeah, you mentioned just about the number of injections over 2 years. And I know sometimes with cost evaluation, that's kind of brought into it thing. But I think once you look at the number of injections over 2 years, it is actually remarkable. It's so different.
Yeah, especially when you compare it to existing therapies. Mm-hmm. The aflibercept 8 milligrams really makes sense. And that's coming from the U.S., where, frankly speaking, we have the highest drug prices of any place in the world. But when you average it out, and even being generous on the Eylea 8 milligrams, if you're doing 9 injections over 2 years, that cost is nearly equal to what we saw in the patients that were treated with Eylea 2 milligrams every other week or every other month after 3 loading doses. Mm-hmm. So that cost is neutral. And then for those patients that are able to be extended out and treated less often, that's fewer examinations, it's fewer images, it's less overall cost for the healthcare system.
And you mentioned a little bit about safety, and I know the topic of kind of vasculitis and endophthalmitis is really kind of strong right now in the ophthalmology community as well. And you kind of mentioned about, well, if you're bringing them in for less injections, that's just decreasing that risk of any invasive kind of thing happening. In terms of safety, otherwise as well, with volume and some of the other things that always come up with intravitreal injections, what are your kind of thoughts with the newer agents that are coming out?
Well, I'll tell you, going to a 70 microliter injection is a change, and it is a bit different. So I know there's concerns for people who haven't utilized it. Mm-hmm. We've had a little bit of an easing into this aggressively, because we've also had geographic atrophy therapies. Yeah. And I'll tell you, if you want a controversy, GA therapies are very controversial. Yeah. But those are 100 microliter injections. So much higher volume. We do see more pressure issues there. Yeah. In comparison, 70 microliters is a walk in the park. Yeah. And we don't have to do taps, AC taps, or paracentesis or anything else to try to get that pressure down. It comes down with just in a few minutes. Mm-hmm. And you know what? Even for our patients that are very sensitive to the existing 50 microliter injections, even if you're giving them a reduced dose, it's concentrated. Yeah. So those patients are still going to benefit, because they're going to get, instead of 4 times the dose, they might get 3 times the dose. Yeah. And that's going to still give them extra durability.
Yeah. And Dr. Fan mentioned about the ocular massage technique. Can you kind of describe that a little bit further?
Yeah. So ocular massage is a technique by which we place pressure on the eye. You can either do it digitally, or you can do it with a Q-tip. I like to do it with a Q-tip because I'll soak it in lidocaine. Okay. And then that will allow me to apply some anesthetic to the area I'm going to inject, and just very gently massage that eye, holding that Q-tip in place. Just kind of allows more egress of aqueous out of the eye, softens the eye up just a bit before we actually do the injection.
Nice. And I think another thing that's come out is just the beautiful images that are coming up on the screen. So a lot of cases that are being shown, and a lot of kind of AI and fluid segmentation and fluid volume. In terms of, now that you have these great new agents, are there digital tools that you're using as well to kind of showcase what they're actually doing?
Yeah, so certainly OCT is beneficial for our patients. Now, that's been around for quite some time. Some of the excitement, though, is what are we going to be able to do when we have AI-enhanced OCT? Mm-hmm. So OCT where we can actually go back and AI can not just analyze how a patient's doing going forward, but might be able to look back at that patient's entire history and give us some suggestions and recommendations.
Wow.
In addition, in the next 6 months, we should have approval of home OCT in the US. And that'll be used for our patients with exudative age-related macular degeneration. And it will allow us to follow those patients. I'm always nervous when we have any agent that can allow us to go and take injections on patients out beyond 4 months because my comfort level is not there yet.
Yeah.
But if I had an OCT that I could follow that patient and know exactly when fluid was starting to reappear and initiate treatment at that point, I'd feel more comfortable actually getting
100%.
the full benefits out of these higher dose therapies.
And how do you see that working? Is it that a patient will kind of scan their eye is it like week? Is it more daily? And then what is the triaging approach? Is it, okay, there's fluid now, you got to get it in right away? Or do they have kind of a buffer period?
Yeah, so it's going to be multiple times a week.
Okay.
And it's going to be self-initiated by the patient. They'll have it's a little bigger than a shoebox at home, and it's actually going to perform a 3 mm scan of the foveal center in the area around the fovea there. So it's not our full 6 or 8 mm scans we're used to seeing, but it's pretty good. And the resolution is actually very on par with what we're looking at now. They'll utilize AI to analyze the images, and then a doctor will review the images. And there'll be a portal that patients can be, it can be recognized then by the doctor and their staff, and the patient can be alerted to come in, and we can get them their treatments.
Well, that's amazing. I know through all this discussion, what is coming across very clearly is your love of technology. Is there one thing in particular that you're super excited for and can't wait to get your hands on?
Oh my gosh. In ophthalmology, we're on the verge in Retina of having next generation machines too. So about every decade or so, there's new release of equipment and machines that we do surgery with. And on the very near horizon over the next couple of years, I think we're going to see new machines from all 3 of the big manufacturers.
Nice.
And what's going to be in these machines is going to be incredibly exciting.
Yeah.
And the way it integrates, we love 3D heads-up surgery with the Ingenuity system. Being able to integrate those machines with that technology, I think is going to be awesome.
Yeah. Last question is, we at Adam Brooks have a robot operated kind of operating room. Do you think that's ever going to be on the horizon for ophthalmology, or is it too micro over surgery that maybe that's going to be probably the last part that we see kind of robotic assisted surgery?
No, I think robotic assisted surgery is the future, for retina. Granted, it's going to be very fine, movements that have to be achieved, but the advancements that we've seen in robotics, combined with AI, I think will actually see us achieve that probably in the next decade or so.
Okay.
I think we'll still need a surgeon to be able to drive the robot.
Yeah.
But I think the ability of the robot to react to a patient's subtle movements, to be able to allow surgeons to operate longer as they get older and maybe have issues with tremor and whatnot, I think it's a potential for a real game changer.
Fantastic. Well, this has been an interesting discussion. Thank you so much for tuning in, and we can't wait to bring you more content from COPHy.
ClinicianLink.ai